Hello, this is Dr. Sargisian with a small focused review for exam 2. Just a reminder that focused review will cover only select topics for this exam. There are many geriatric syndromes, but I would like to bring your attention to one of the most common ones, falls. Falls are preventable, but unfortunately they still occur. At any age, person may fall, but at advanced age, the fall may have very serious consequences and it may lead to fractures and even death. Usually, the fall is related to an environmental factor in elderly. For those of us who worked in orthopedics, patients who had a fall and a subsequent hip fracture often fell at home. Sometimes small animals such as dog or a cat presented a tripping hazard, and in other cases area rugs or furniture contributed to the fall. Fall prevention should start from the modification of the living space. Also, you may consider intervention to reduce the negative consequences of falls such as fractures. To do that, you may consider introducing osteoporosis screening, vitamin D supplementation, and calcium supplementation. Another topic I'd like to talk about is dysphagia. Dysphagia has many sources, and some of them can be modified or eliminated. Others may be functional and difficult or impossible to modify. Anticholinergics, anything that contribute to gastroesophageal reflux disease or gastroesophageal reflux in general, drugs or meals, inadequate food intake, inadequate fluid intake with meals, or inadequate fluid intake with medications. All of these may consider to be a contributing factor for dysphagia. So when we talk about fluid balance in elderly, how to evaluate it? Traditional methods such as turgor are not reliable. You have better results or better picture when you are evaluating the laboratory workup. So to do that, you can look at hematocrit or hemoglobin ratios, BUN and creatinine. Also, you can do the same when you are looking at the nutritional status. You may consider to look at laboratory workup to determine the nutritional status. Albumin values are still very important. However, if you are dealing with refeeding syndrome, you may consider at phosphate values. Lower phosphate values may signify the presence of refeeding syndrome. So elderly patients also may present with weight loss related to malnutrition, and sometimes, unfortunately, it's a malignancy. Regardless of the source, unintentional weight loss should be a cause for an alarm. When you are considering an unintentional weight loss, how much? If patient is losing 10% of the baseline body weight, this may signify a serious problem, such as protein, calorie, malnutrition. Again, it's 10% or more, obviously, of the baseline body weight. If patient is obese or overweight, you still consider that weight as a baseline. The baseline, what you had previously before, and when patients had stable weight. Dysphagia may be one of the causes for malnutrition. Obviously, if patient has difficulty swallowing, they may not be able to eat and have limited food intake, and as a result, a nutritional impaired status. There may be a different presentation of dysphagia depending on the origin of the dysphagia. If patient present with choking or coughing, this may be representative of pharyngeal or oropharyngeal dysphagia, while the sensation of food being stuck may be related to an obstruction. Obstruction can be something like esophageal stricture, esophageal web, or even a tumor. On the other hand, oropharyngeal dysphagia is considered a functional swallowing disorder, and the best way will be to evaluate to conduct a video fluoroscopy. So video fluoroscopy is conducted usually by speech pathologists, and it will give you a good idea of what's happening with swallowing functional status. Another name for video fluoroscopy you probably heard, it's modified barium swallow or modified video barium swallow. So this will be a great tool to determine the origin of dysphagia if you are suspecting a functional swallowing disorder. So while we're talking about nutrition, let's talk about PEG tube placement. When it's appropriate, when it's recommended, when it is not recommended, when it's not appropriate. Let's look at two different examples. And in first example, you are dealing with a patient who has no cognitive dysfunction, no limitations, an elderly patient who has functional dysphagia. You may consider that they had a stroke before and it didn't leave them with any cognitive dysfunction or any physical dysfunctions, with the exception of functional dysphagia. Because this patient has functional dysphagia, they have repeat aspiration pneumonia episodes. And in this situation, you may consider a placement of PEG tube. On the other hand, if you are dealing with a patient who has Alzheimer type dementia, in that situation, PEG tube placement will not contribute to improvement of quality of life, and it may result in prolongation of life. And this is it for now, and I'd like to thank you for listening, and good luck on this examination.